Then let's talk about the pathophysiology of atelectasis. When we talk about atelectasis, we are talking about partial or complete lung collapse. Is it? Yes. We talk about partial or complete lung collapse. Could be of a lung or a lobe of the lung. And if there's a collapse of part of the lung or a whole lobe of the lung, then it's going to result in reduced or absent gaseous exchange taking place in the affected area. So we look at now the pathophysiology and what will happen, more especially now leading to the alveolar collapse and also impaired oxygenation. Because again, even with atelectasis, there's going to be now impairment of oxygenation. So with atelectasis now, fresh air will not be able to reach the alveoli, and oxygen and carbon dioxide cannot be exchanged properly, and that's going to cause now the hypoxia and many other complications that we'll talk about. We have various types of atelectasis: compression atelectasis, absorption, relaxation, rounded atelectasis. All these are various classifications of atelectasis. Compression occurs from lesion of a thorax compressing the lungs. Mostly happens in congenital emphysema. We talked about emphysema the other day. Absorption, where there is reduction of nitrogen concentration in the lungs, which causes a collapse. We know that, of course, there's also levels of nitrogen concentration in the lungs, and we know their role is. So when there is now reduction in that, then causes lungs to collapse. Relaxation usually results from pleural effusion or pneumothorax, accumulation of fluids within the lungs, which now eliminate now that contact between the parietal pleura and also the visceral pleura, and that causes now the lungs to collapse. The adhesive, usually from deficiency of the surfactant, which can be seen mostly in patients with the acute respiratory distress syndrome. The cicatrization, which is now scarring of the parenchyma from necrotizing pneumonia. The rounded atelectasis, the scarring of or pleural scarring, more especially in those with the asbestos-related pleural disease, and also those with TB. So usually atelectasis will result from blocked airway. That's obstruction of the lungs, or from pressure from outside the lungs. That's the non-obstructive atelectasis. Usually, which can happen mostly, atelectasis can mostly happen, mostly can be seen in those patients who have undergone any form of surgery. That's why when you will be going to the hospital very soon, one of the things we'll be advising you for patients who have undergone surgery, we talk about now turning of the patients and also encouraging ambulation, encouraging the patients to get out of bed. Why? You don't want fluids to, too much time on the bed will now allow fluids to accumulate in the lungs, and that's going to cause the atelectasis. So with the obstructive atelectasis, which is usually now from blockage of the airway. Blockage can be from mucus plug, can be from a tumor or from a foreign body, from a blood clot. That obstruction is going to prevent now air getting into the alveoli. And now that means that the air that is being trapped from that obstruction will now progressively become absorbed into the bloodstream. And that's going to cause now alveolar collapse, because now there is no ventilation, there is no gas exchange taking place. For the non-obstructive, could be injury to the chest, pneumonia, could be pneumothorax, could be a tumor that is pressing against and deflating the lungs. And again now, with all that, it's again going to lead to inadequacy of ventilation, inadequacy of gaseous exchange taking place, and that pressure now from any of this is going to compress the alveoli, and the alveoli now will not be able to expand during inspiration, and that's going to lead to lung collapse. So you can see here, reduced ventilation or blockage, which causes obstruction of passage of air from and to the alveoli. So that air will be trapped, and that air that is trapped will be absorbed into the bloodstream. So that means that now the area of the alveoli that is affected will be airless, and the alveoli will collapse, and that is atelectasis. So patient will now present with difficulties in breathing. They'll present with chest pains. There'll be cough, which is accompanied by sputum production. There'll also be respiratory distress that can be seen in this patient. There'll be central cyanosis because now ventilation is taking place. That means that now there is no not enough of the blood getting to the body tissues. There'll be anxiety, there'll be fever, there'll be tachypnea, which can be seen in this patient. So for you to diagnose that, I know it's not part of it, but you can talk about it. History taking from your patient, the physical examination, which will show you decreased breath sounds, the chest x-ray, the CT scans, which will show you again the air that is trapped in the lungs, pulse oximetry, which will show you that the patient oxygen concentration levels are decreased, the bronchoscopy, which you can be able to visualize, more especially in cases of presence of a tumor, blood gas analysis, that's the arterial blood gas analysis, which again will show you that the oxygen concentration levels in the body tissues are decreased. Swali hadi hapo?